ask you to start the recording if you would, please. I'll have a little start over here.
It looks like it's going, so
Okay.
you're good.
All right. Okay. Again, good afternoon. I'm Lisa Emerson. I'm a Senior Policy Advisor with the Division of Financial Regulation at DCBS. Welcome to House Bill 2002 Gender Affirming Treatment Rules Advisory Committee meeting number 7. We're going to go ahead and forego introductions since we've all been collaborating together now for several meetings. I'm going to start the agenda, kick the agenda off by just doing some housekeeping reminders, and then we will go ahead and jump into reviewing the written comments that we received since the last RAC meeting in June. So as far as housekeeping goes, just some reminders. If you could please mute your lines if you're not speaking, that will be helpful. Also, please, raise your hand if you would like to make a comment, and please wait to be called on by Brooke or I. Also, just a reminder that discussion is going to be limited to official RAC members and division staff during the bulk of the meeting. Discussion and review of the draft rule. Also the review of the comments, the written comments, and the discussion of outstanding issues, but there will be time for public comment for interested parties that would like to comment. I would like to invite those interested parties that would like to make a public comment to put the request to do so in the chat so that we can kind of keep track as we get to that point in the meeting. All right. So I think we'll go ahead and just jump right into things and start with reviewing the written comments that we received since the last RAC. I'm just going to go in alphabetical order and invite those commenters to briefly summarize their comments. And it's appreciated. So let's start with Basic Rights Oregon. I believe it would be Seth, if you'd like to do an overview of your comments, we'd appreciate that.
Sure, thank you. Let me just pull up my letter real quick. So Basic Rights Oregon appreciated the ability to give feedback on the revised rule. And in our comment letter, we addressed the impact that long wait times can have on our patients that reach out to us, especially in rural areas. And given the importance of sufficient access, we supported Section 8, addressing the ambiguity of unreasonable delay. And following the research that had been done by some of our fellows and interns, we're able to add the comparisons from other states around the existing network adequacy rules to prevent detrimental waits for gender affirming treatment. So we agreed with the unreasonable definition provided in the last RAC meeting. We also looked at the text of HB 2002 and supported the intent of 2002 and encouraged the DFR to uphold the Federal No Surprises Act. I know balance billing was requested in the last RAC meeting, and the intent of that section was that when patients in our rural areas must seek out of network care, or in any of our areas in Oregon, they've been facing the financial burden and reached out to Basic Rights Oregon for support. So we'd just like to address that request for balance billing and consider how these patients have been financially burdened, and the intention of the original language in the HB 2002 process was to look at reducing the burden of cost for these marginalized patients who are low income, who don't have the capacity and access to financial means, and also don't have any providers in their networks who can provide the care and have been left out of care due to this. So I think that was the extent of our letter of intent, and I appreciate the time.
Thank you, Seth. We appreciate it. Let's go on to Cambia. If you could bring those comments up, that'd be great. Karen, that's helpful.
Great. Hi, this is Antoinette from Cambia Health. Hello. And I'm just really going to summarize our comments. Real deep summary here. One of the things that our comment letter addressed was when a member received care out of network. Again, we emphasized that the DFR please allow insurers to use their current processes of trying to assist the member with finding care, in network and also in state. So we were very grateful for the DFR clarifying at the RAC meeting that while the DFR would not specifically include such a provision in the rules, that we are permitted to use our current practices of working with the member to find an in-network provider without unreasonable delay to their gender affirming treatment. And also, should we be unsuccessful in finding that in-network provider for the member, that we can pursue other means to provide the member the care they need. And one of them, for example, could be having a special case agreement with the out-of-network provider. We felt that this was really important because it's not only cost effective for the member and the insurer, but it also allows the member to remain in state and close to their home, and also to find the best and convenient care for them. Our comment letter also addressed the issue, again, expanding to reimbursement of out-of-network services, that in-network cost sharing. We also wanted to draw attention that, and also thank the DFR for confirming that, should a member seek these out-of-network gender affirming treatment services, unless there is a prior agreement in place with a carrier, providers will be allowed to balance bill because the cost of the service exceeds cost sharing for in-network services. Customarily, this is what out-of-network, this is what happens when a member seeks, service out of network. And really the definition of out-of-network is that the provider can also balance bill. And another of our comments had to do with the definition of unreasonable delay. The prior version of the draft rules included the CMS requirements, which we felt was very stringent and unreasonable, considering carriers will also be required to ensure that enrollees seeking an appointment are able to schedule an appointment within the time frames and the time rules at least 90% of the time. So given the current environment in Oregon, where there are workforce shortages, for example, and the demand for providers is more than the supply, it's unrealistic for carriers to meet these CMS timeframes. And we really highly recommend that the DFR postpone defining it and relying on its current network adequacy law and rules until the anticipated rulemaking begins to revise the existing network adequacy standards. And lastly, too, it is still unclear whether we will be allowed, and this has to do with overarching procedures that are considered experimental or investigational. It's still unclear whether insurance will be allowed to exclude, such procedures that are included in other sections of WPATH guidelines, but are still considered experimental or not widely agreed by medical professionals to be safe. That's really the only outstanding issue we would address, so that it is uniformly applied with all carriers, whatever clarity we do receive today. So thanks again for working with insurers and the public and interested parties in this rulemaking to get us where we are today.
Thank you, Antoinette. Okay, let's go on to Kaiser Permanente.
Good afternoon. Thank you for allowing us to have public feedback on the draft of the regulation. Our comment letter focused on three main areas. We asked in the utilization review section to clarify that a health benefit plan's requirement for use of in-network providers and referrals for out-of-network services are permitted. We noticed that you incorporated the WAC that I cited, the 836.053, 1200, into the draft that we will discuss today. So thank you. The second one is about a technical change about allowing sufficient time for reviewing physicians and healthcare providers to take the continuing education course. We are supportive of having healthcare providers take that course, but given the timing of this rulemaking process and when the effective date would go into effect, we recommend that the comply by date for continuing education be at least 6 months later than the effective date of the regulation. That just allows people time to actually enroll in and take the class and not have an unintended consequence that utilization review is put on pause because perhaps there are staff that don't currently have that training. And then similar to Cambia, we had a comment about the stringent timeframes for access to gender affirming treatment services. There are indeed workforce shortages in both Oregon and the United States. And the stringent timeframes that are in the CMS standard would be very difficult for health carriers to meet based off of access to operating rooms and trained healthcare professionals that can safely and effectively provide the necessary treatment. And we do, empathize with patients. We would like timeframes be more effective in getting patients access to care in a more timely way. But we also have to bounce that up against the reality of what the state of access within the state is. So we recommend pausing on defining unreasonable delay and then considering it further when the DFR considers network access regulations as a whole so that we can discuss that within the context of other behavioral health and physical medicine services. So we look forward to the discussion today and thank you very much.
Thank you, Marlene. And next, let's go to Moda.
Good afternoon. Thank you, Lisa and Brooke, for the opportunity to comment. I'm kind of just echoing what others have said. Moda's comment letter focused on our concerns with the proposed changes to the definition of unreasonable delay, which seems to have been rectified with the latest round of proposed verbiage. Just coming back to the fact that the bill does not suggest or require a unique definition of unreasonable delay, and that any changes to that definition should be part of a larger network adequacy conversation. And not just specific to these specific services being discussed in the RAC today. And that pretty much summarizes it. Thank you.
Thank you, Scott. And then next and lastly, we'll go to Oregon Consumer Justice.
Thank you, Lisa. Thanks for this opportunity to share some of the overview of what we included. And similar to what Seth had shared earlier, I mean, we expressed concern about long delays, and so did support the Section 8 that was in the previous version, and then did add some language modeled after California and Washington's existing network adequacy rules to just prevent detrimental waits that would harm patients. We also talked about there was, as far as the CCO network adequacy requirements, there isn't anything that defines wait times for surgery explicitly. So we did include in D, in 1D at the bottom of the screen, some language around surgery wait times. And then, as Seth had mentioned, this work is based on a review of state network adequacy standards and included data from the rules of 21 different states. And then finally, we do have concerns about balanced billing when patients must seek out-of-network care, especially if there are long wait times. And so supports the intent of House Bill 2002 to uphold the Federal No Surprises Act. So thank you for your consideration and your time today.
Thank you, Chris. So that concludes the review of the written comments from the last RAC, and I would now like to transition over to Brooke Hall, my co-analyst, who's going to talk about the current version of the draft rule.
Hi, all. Brooke Hall, policy analyst for the division, and Karen is pulling up the rule now. There were not a ton of changes in the current draft of the rule, but I will go over each of them with you. The first one is to section 3. As mentioned earlier, we did add that utilization review practices must be consistent with the OAR listed there, which is the current Oregon Administrative Rules for prior authorization requirements for health benefit plans. And that was added at the request of a RAC member. It's just confirming that any utilization review practices must be consistent with the current prior authorization requirements that the state has. Any questions about that addition? Okay. The next change was to 5 big C. So if you scroll down, Karen, and this section in general did have some changes just to the lettering and the numbering just to be consistent. So I think that is true throughout the document, just some changes to the lettering and numbering to be consistent. But in 5C, we did add an effective date of July 1st, 2025. For reviewing providers to complete the WPATH program, training program, or the equivalent course. And this, again, was at the request of a RAC member, and it's really just to allow time for providers to meet those requirements, given that the effective date of the rule is January 1st, 2025, which is coming up pretty quickly. So this is really just to make sure that reviewing providers, have the time to take that training prior to after the rule goes into effect. And Scott, I see your hand up. Go ahead.
Hi, yeah, thanks, Brooke. Just scrolling back up to 5A when it's referencing the Oregon statutes about external review. Because it says the reviewing provider, it's on down, sorry, it's on the next page, the top of the next page. It says the reviewing provider must meet the criteria for external medical review. Is that, and maybe I'm just misconstruing the intent here, is the intent that only external reviewers can review these claims and make adverse benefit determinations? I didn't believe that was the intent, but that statute is all about IRO review. So I was just confused. Apologies if I have something misconstrued.
No, I think, Lisa, did you have that statute? You want to share it? I think you prepared for that, right? I mean, really the intent of that was just to ensure that reviewing providers have the background and the expertise necessary to do the review, and most of those requirements are in that particular OAR, and it is those sections. It's not the whole OAR that we're citing, it's just those particular sections. So Lisa, if you want to show it just to provide a little more clarity.
Yeah, that's correct. Let me find that here. Got a number of screens up. Oh, sorry. Yeah, I'm going to need a minute. Sorry. I'm just going to have to pull it up. Sorry for the delay.
No, it's no problem. I'll go on and then we can come back to it when you're ready. Does that sound okay?
Thank you. Yes.
So we'll come back to that, Scott. Is that all right with you?
Sounds great. Thank you.
Okay. Any other questions about either the language that was added in section 3 or anything in section 5? All right, I'm going to see if I can pull up that OAR really quick.
I guess I have just a question. Seth Johnstone, Basic Rights Oregon, he, him. Just was curious if folks haven't had the training, is that going to delay benefit review or the access to care for patients if being delivered? Do those not get processed until July? Just curious how that would operate.
That's a great question, Seth, and I don't know the answer to that. Does somebody on the on the insurer side who is aware of what that process is?
Brooke, I actually just had the same question on how we're supposed to operationalize that
Yeah.
from a reviewer standpoint, because we wouldn't want to, hold member reviews of these determinations for that long. So is it until that time, issuers can provide, the requested documentation that is required throughout the rules, and then after that date, we have the WPATH training on top of that. Our goal is certainly not to have someone who doesn't have training in this issue completing these reviews. But yeah, I have the same question of how we are expected to handle that piece.
Yeah, I think that's a really good question that unfortunately I didn't think through well enough before the RAC. So I'm gonna write that down and take it back for consideration, and we will definitely come back with some kind of answer about how this would effectively look like if it was operationalized for the July 1st date. I know that we have done this in other rule sets, and so there likely is a process that I'm just not thinking of right now. Go ahead, Antoinette.
Yeah, so you had mentioned it was a RAC, it was at the suggestion of a recommendation of the RAC member who suggested it. Did they also add the date or recommend the date? If so, then I'm interested to know why the July 1st date, knowing that the rules are going to be effective 1/1/2025.
Yeah, the date was suggested from a RAC member. I believe it was Merlene, not to put you on the spot, Merlene. But the July 1st, 2025 date was just, the idea is to give those reviewing providers time to complete that training, given that, currently there are some limitations to taking the WPATH 8 training, and really the idea was, we want to be able to provide enough time for anybody who is reviewing those determinations to take the training before they start doing the review. But I think we likely need to put a little bit more thought, or I likely need to put a little more thought around this. So I really appreciate the questions. I think it's a good point that I need to think through a little bit more.
And I mean, another option, I know, I think we did discuss this, I'm not quite sure. It would be great to have the effective date coincide to when the training must be completed, so that at least it syncs up, it just goes hand in hand, I guess, for like a better word.
Yeah. Yep, I understand. Go ahead, Lisa.
I'm trying to share my screen. So when you're ready to go back to the reviewer criteria under external review, we can look at that. So I don't know if I'm already sharing my screen or not, but just let me know when you're ready.
I'm going to I'm going to let Merlene ask her question first, and then we'll go back to you. Okay, Lisa? Go ahead, Merlene.
Hi, I didn't have a question. I just wanted to clarify to Antoinette's point that really I was just hoping for there to be a lead time between when the regulation got adopted and when the compliance requirements would apply for that continuing education. And I would support Antoinette if we also have the other criteria, you kind of be tracking along with that same time period. My main thing is I don't want the overall regulation to go into effect and us to have unintended consequences where people are scrambling in 30 days to try and get stuff in order when coursework and training may not be available in that time frame. So thank you.
Yep, appreciate that, Merlene. Thank you. Any other questions or comments before we look at the rule Lisa has pulled up?
Brooke, I was just going to say, this is Scott. I agree with Merlene, and I agree with that approach. I just wanted to make sure that it was operationalized and we had clear guidance. So was not dissenting to the approach, just want to make sure it's clear.
No, I completely understand, Scott. And we will be talking later in the rulemaking, or in the RAC, about some outstanding issues and providing guidance for those outstanding issues. So I will add this to the outstanding issues. Great, go ahead, Lisa.
So one of the challenges is I can't share my screen and talk, so I'll, or unmute myself. So I'm going to go back to the rule, and you'll be looking at me. And I believe it was this here section. This rule is, oh, here we go. 836.053.1325, procedures for conducting external reviews. Go down to section 6. And we wanted to highlight these requirements for reviewers having the credentials similar to the credentials of the reviewers under the external review, not intending to say that only the reviewers that you utilize have to be from an independent review organization, but rather meet this criteria and then some additional criteria that we have put in rule.
Okay, thank you for clarifying, Lisa.
Okay, you're welcome.
Great, and then there's just one more change to the rule, if you can pull it back up, Lisa. I mean, sorry, Karen. Okay. And then the last change was in section 8. So if you can scroll down, Lisa or Karen. This is the language that was included at the last RAC around the definition of unreasonable delay. And this was removed from the rule because of the reasons that were discussed previously during the comment time, which is, we have received approval to resubmit our network adequacy LC for 2025. And we will start to do some stakeholder engagement regarding the LC pretty shortly. And currently the plan is to address quantitative standards in the network adequacy LC through a rulemaking process if that concept does pass. And that would include discussing with the RAC whether a definition of unreasonable delay is needed and what that definition would look like. But currently, the legislative concept applies the network adequacy statute to large group employers, and it also would add specific quantitative standards to the network adequacy statute, which Oregon currently lacks, and those include time and distance standards, appointment wait time standards, and geographic standards. And so we will be making those changes in the network adequacy rules rather than in the gender affirming treatment rules if that LC, if the concept does pass. If something happens and that concept doesn't pass this session, we'll likely take a look at the network adequacy rules and determine whether or not they need to be opened up to kind of make any changes both for network adequacy and for gender affirming treatment. Any questions about that? All right. So that concludes the rule review. I think, oh, Antoinette, I'm sorry, I didn't see your hand. Go ahead.
That's okay. I raised it last minute. So I just want to understand that. So that means status quo remains when it comes to network adequacy, right? We are going to currently follow what is in statute and rules right now with respect to network adequacy when it comes to gender affirming treatment.
Correct. The current
Okay.
gender affirming treatment rules do require that you follow the network adequacy statutes that are currently in place. And if we did make updates to the network adequacy statute, after the legislative session, it would still require you to follow the network adequacy statute that we put into place at that time. So whatever the current network adequacy statute is right now. I'm sorry, whatever the current network adequacy statute. So for right now, it's what we currently have. If we make changes to the network adequacy statute, it would be whatever those changes are in 2026. Does that make sense?
Yes.
Okay. Seth.
So to clarify, a patient would possibly be able to go out of network if a single case agreement was agreed upon after prior authorization. Okay, just wanted to clarify. Thank you.
And Scott?
Yes, Scott from MODA. So I know this is in the bill, but there were some comment letters on it, and I think it's important to clarify in the RAC about other out-of-pocket costs for members, because we want to be really transparent about what members will and will not be responsible for. And I think it's important to clarify that we are talking about in-network cost sharing. We are not talking about balance billed amounts. If we were meant to cover balance billed amounts as insurers, there would be no incentive for providers to ever contract with us for single case agreements, to work with us at all, because they're just going to be paid the balance bill amount by the provider. But I also think it's, or by the issuer. But I also think it's really important just to make that clear for members, that they try to work with issuers to find in-network services, and for us to work and find single case agreements whenever possible with providers. I don't want to have, and I would disagree that the No Surprises Act would apply at all in this case. These are prior auth services that we're working through. This is not NSA applicable. And so I just want to make sure that's clear, because I do not want members to be surprised. We'll try to make that very clear in our prior authorizations. Anything above the MPA for out-of-network approved services, they will receive in-network cost sharing, but that does not negate the ability to be balance billed. I just want to make that really clear.
Yeah, I appreciate that, Scott. And Lisa is the balance billing expert on our team. So Lisa, if you have anything to add, feel free.
Yeah, that was definitely going to be something that I thought we'd be talking about in the other outstanding issues, things that we need to discuss. And so I wanted to follow up on that. So thanks for bringing it up, Scott. If we could go back to that section of the rule so we could have it up. I think it's.
And Lisa, I'm sorry, this is Antoinette. I thought we did have that discussion during the last RAC. So I'm hoping that you are confirming what Scott is saying. Okay, great.
Well,
because there are other outstanding issues that I don't want us to have to revisit stuff we've already kind of finalized. So, but all right.
And we may need some sub-regulatory guidance, form of showing like scenarios to further illustrate, in order to help consumers, for consumer protection, and also to help the insurers communicate with consumers in this space about how prior authorization and single case agreements work, because the statutes, the insurance code doesn't regulate providers and insurer contracting, contractual arrangements. So there's kind of a limited regulation in that space. But to protect the consumer needs to communicate with their insurer and their provider that they desire to see, or that they are even able to see, and negotiate that situation. However, looking at the law and that language that was brought into the rule, you mentioned, Scott, it states, it's on the next, if you go back up, Karen, back up a page. And we won't park too long on this, but I think we should talk about it. Where is it? It had to do with that, sorry, network adequacy, that we pulled all that out. Okay. Where is it? Not seeing it here. Okay. Right, I think it's right here. In the event, and it's section 6. Nope, it's the network adequacy. So yeah, 7. So what it states here is, in the event that they cannot see an in-network provider without unreasonable delay. Oh, you went too far. You went too far. Go back up. Okay, so the other option is the carrier will ensure that all enrollees have access without unreasonable delay to out-of-network gender-affirming treatment, with cost sharing or other out-of-pocket costs for the services no greater than the cost sharing or other out-of-pocket costs for like in-network. That's a little bit different language than the statute. And so if we go to the statute, it does speak to cost sharing or other out-of-pocket costs. And those other out-of-pocket costs is what I'm wanting to ask one could think that that would involve balance billing. So that's got to all be negotiated with a provider to avoid that scenario. And it just says, insurers, carriers must ensure that occurs. So I would like to have a little bit more discussion. If you could comment on that, that'd be appreciated. I see Scott's hand is up.
Yeah, thank you, Lisa. And that verbiage has been in other rules and part of other rulemaking with no inclusion of balance billed amounts. So if there is precedence for not including balance billing with that verbiage. And I think you
Thanks.
would have to redo the whole cost estimation of the bill if you're going to include balance bills there.
Okay, thank you for that clarification. So I think the main premise is there needs to be, prior authorization is okay. There needs to be a single case agreement if an enrollee wants to pursue out of network care.
And again,
So-
this is Antoinette. We did offer, single case agreement as an example, of what insurers currently do. But if there are other things that is done, some kind of agreement with the provider prior to the member seeking the out-of-network services, then, it also should be allowed. I don't want us to just say it's just single case agreement, because I think there may be other agreements out there that I am not aware of. But again, it's the negotiation between the insurer and the provider to keep that cost for the member, low or reasonable, whatever it is.
Understood. And there are plans that have an out-of-network benefit. So there may be a situation where the enrollee just uses that out-of-network benefit and they would pay the cost sharing associated with that, correct? If their plan allows for them to seek out-of-network care at that particular cost sharing.
If it's in
is that
plan documents, Lisa, I mean, yeah, it would depend
Yes.
on the plan, but yeah, that we would follow the rules of the plan.
Okay.
It doesn't mean we wouldn't try to get them in network
Okay.
care.
Thank you for clarifying. Any other comments or thoughts on this topic? Any other information that RAC members need on this topic at this time? And I would certainly say that you should feel free to, if you still have questions or concerns, to submit that into written comment. And also you can, in addition, comment at the public, hearing at which time that occurs. So we can move on to the next outstanding issue that we are aware of. And I think that has to do with the topic of treatment that is gender-affirming treatment that is considered experimental or investigational. That was raised in a comment letter from Cambia. We did talk about this in past RAC meetings, and we believe that, the law, so ORS 743A.325 is silent on the issue of that topic. And we also believe that Section 3 of the rule will address that issue in terms of carriers being allowed to use utilization review process, including prior authorization. And also the WPATH 8 discusses procedures, treatment, and including procedures and surgical procedures that are not, and they state very clearly, not widely prescribed, if at all. And however, that's an evolving space for treatment. So really it will depend on, that each time an individual wants to request a certain type of treatment, it would go through the carrier's utilization management process. There's the opportunity for appeal, internal appeal, and also external review by independent review organizations. That process exists currently for all types of physical and behavioral health care. So we're not planning to put additional information into the rule at this time. We welcome any comments or questions, verbal from RAC members at this time, or you can certainly follow it up into written comments.
Okay, thanks for clarifying that and pointing to section 3 that we can utilize our current or our utilization review practices, which, you know, to me, again, because I don't think the law intended for insurance to cover those services that are going to be harmful to the member or patient. So again, based on our utilization review practices, if, you know, we find that it is the member's safety may be at issue based on, again, agreed upon medical standards and practices, then, you know, we have that to rely on in terms of how to proceed with covering or not covering the gender affirming treatment. And I'm glad you did highlight that there are other means of following that decision, other means left to the member to take, you know, whether it's an appeal or something else. So I appreciate that clarification.
You're welcome, and I'll pass it to Brooke in a moment, but I should also add that there is the, in the law and in the rule that if a treatment is prescribed by a treating provider, physical or behavioral health provider, that needs to be factored in as well. And it will be, you know, it'll go through the clinical review of, you know, if it's through an appeal process, which is either internal or external. And there's also the external review where other independent clinicians with experience would be looking at the particular type of care that is being sought. But go ahead, Brooke.
Yeah, I was just going to say that I understand the concern here, and Lisa and I did try to work really hard to draft some language to add to the rule that would have addressed this concern. However, you know, we did attempt a couple different versions, and unfortunately it each of those led to some unintended consequences. And so this might be an area where we do need to issue some regulatory guidance after the rulemaking hearing that just goes through different scenarios and our interpretation of how you know, those should be addressed. But I just wanted to let people know that that may be an option that we do in the future.
Thanks, Brooke.
Brooke, this is Rick Blackwell from Pacific Source. So any sub-regulatory guidance would probably be in the form of a bulletin, and like all interested parties would be able to have a opportunity to review and comment on that. Is that correct?
Absolutely, yes.
All right. So in the space of any other outstanding issue, one other topic I think we did discuss in a previous RAC, but we'll go ahead and just briefly revisit it again, is the topic of does the rule need a definition or some information regarding detransition being a form of gender affirming treatment? We don't believe that it does. We think that it is addressed in the statute, which has been pulled into rule under section 4B, capital D, revisions to prior forms of gender affirming treatment. That would encompass detransition, which is a very broad medical space, behavioral space, and a lot of that information is in the WPATH 8, and also would be, you know, subject to the prescribing or treating provider, physical health provider or behavioral health provider, if they feel that it's medically necessary. So we don't feel that further information is needed in the rule. And do any RAC members have any questions or comments or need any additional information for this topic? Okay, hearing none, I will go ahead and pass it back to Brooke for our next agenda item.
Thanks, Lisa. I believe the next agenda item is the opportunity for public comment. I did note that Paul Turtle would like to give public comment. Is there anyone else who would like to give public comment at this time? If so, just raise your hand. Okay. I got Mary Beth and Paul. So we'll start with Paul. Go ahead.
Hi, thank you. So this is Paul Turtle, and thank you also for bringing up the topic of detransitioners. I appreciate that. I think I am concerned that some aspects of it may not be entirely clear, because I have been hearing from detransitioners about difficulty in accessing care and coverage, and that the kinds of questions that I'm seeing come up are things like, say the provider doesn't believe it's covered and therefore they're not going to get started, and sort of that lack of communication, not merely from the insurers but also from the providers. Questions about what coding to use, like what diagnostic code to use and things like that. So I think there are questions that are out there and there is confusion. Maybe some of that could be addressed through a bulletin or some other kind of guidance. To clarify that would be helpful. And I really would encourage you to work directly with detransitioners as a constituency, as part of that decision for whether it needs to be included in the rule or how to address it. Because I think, again, I'm just a consumer representative, not a detransitioner. I'm just passing along what I'm hearing from the public. And I think working directly with detransitioners to hear what their concerns are and figure out how to address them, I think would be really helpful. I know one detransitioner did apply for the RAC and then was turned down. So I would encourage you to do that. I think second, just more broadly as a process issue, I am concerned that you don't have any small business representation on the Rules Advisory Committee. It is a requirement of the Administrative Procedures Act to, consider, the needs of small businesses. And I think some of the things that you have addressed in terms of like defining WPATH 8 as a standard of care, something that could affect some of the small businesses that are applying, that are seeking reimbursement. So that's a concern. And then lastly, there has been a lot of press in the last couple of months in like New York Times and Economist and so forth with some sort of new information about sort of the development of WPATH 8, and I would certainly encourage division staff to be reviewing those materials. So thank you.
Thank you, Paul. Next, I have Mary Beth.
Thank you very much. I just wanted to raise concern about anything being put into regulations that weren't part of the original intent of the bill, if specifically WPATH 8 guidelines were called for or training from WPATH was called for, or whether or not guidelines and training could come from more broad evidence-based sources. So I just wanted to raise concerns about that. Thank you.
Thank you, Mary Beth. And Seth, I saw your hand up and then it went down. Did you want to make a public comment?
Sure, if that's okay. I just wanted to address the use of detransitioners as a noun or definition phrase for people. I just wanted to note that the term can hold a wide array of possible meanings for folks, leading to inconsistencies in its usage. And so detransitioning or accessing a dynamic amount of medical interventions for gender affirming care and treatment can mean of many things. For some folks who transition socially, it can entail a change in name or pronouns or expression. For those who've received medical treatment, it could be halting hormone therapy that you've received as you've reached a certain status of a place where you feel less dysphoria, or for others, it could be accessing an additional procedure after a complication So I just want to address the usage of the term being quite varied, and challenge our notion of it being a noun for individuals, because there's a wide definition of access amongst our patient population. And to just reference that in this process of conversation about detransitioning, many folks also may not have had procedures available in the years in which they were accessing care. And now those procedures are studied and presented as safe for patients, and the recognition of non-binary identities is also recognized by providers in ways it wasn't in the past. And so folks may return for care that honors their current identity, more authentically than in our previous models of healthcare. So I think there's a wide definition, and I just wanted to add that into the conversation here, as we look at the term and language used in statute, which addresses revisions are covered, and providers prescribing within the standards of care, are also a covered procedure in this. So just wanted to add that into the conversation.
Thank you, Seth. I appreciate that. Does anybody else have any public comment to provide? Great, hearing none, I think the next part of the agenda is next steps. So our current plan is to move to a rulemaking hearing. We likely will be scheduling one soon, so be on the lookout for that. There are some, as we discussed earlier, some outstanding issues, which likely won't affect the rule. The only one I think that we discussed today that may have changes to the rule is the issue of the issue of the training and the July 1st date. So we'll take another look at that and whether there needs to be changes to the rule. But we do plan to move to a rulemaking hearing. If you'd like to provide any feedback on the draft rule, please do so by the 21st, which is 2 weeks away, so August 21st. And if you have any feedback on what should or shouldn't be included in sub-regulatory guidance, or any bulletins that we may issue in the future, you're welcome to include those in your comment letters as well. And I just want to encourage all RAC members to attend the public hearing and to provide any written or verbal comments on any issues that you think need to be further addressed or clarified, so that we can address those. Any questions?
Brooke, this is Rick Blackwell again from Pacific Source. Are you looking for any feedback on the statement of need and fiscal impact?
Yes, I believe we discussed that maybe 2 RACs ago, 1 or 2 RACs ago. I'm happy to send out our draft of the statement of need and fiscal impact after the RAC. And yes, if you have any comments or suggestions for the SNFI, please feel free to provide those as well.
Great, thank you. I may have missed a meeting or somewhere along the line, so sorry about that. But yeah, I'll look at it.
Yeah, no problem. We'll send it back out just to make sure it's at the top of everyone's inbox. Any other comments, questions? Okay. Well, I thank everyone for your time today. Again, it's always a very enlightening conversation. Oh, Antoinette, you're always...
Sorry, one more thing. So with the outstanding issue of the training for the provider, should we, for example, if we do submit comments on that by the 21st, would we get a draft before the hearing where we will, where the rulemaking, where the hearing will be based on that as well?
Yeah, so if there are any changes that happen to the draft rule, I will likely do the same that I did for the Well Women draft. I'm sorry, the Well Women rulemaking. If any of you were involved with that, there were minor changes to the draft rule just prior to the hearing, just to some challenges that we found with the rule. And so that was sent out as a draft to the RAC prior to the rulemaking hearing, with an opportunity for them to review the draft rule and provide any comments prior to the rulemaking hearing. So if we do make any changes to the draft rule, we'll be sure to send it out well before the rulemaking hearing so that you have an opportunity to review it and an opportunity to provide any comments before the rulemaking hearing as well. And again, you're welcome to provide comments, either written or oral, during that rule making hearing. Anyone else? Okay. Thank you very much for your time today. I appreciate you all.
Thank you.
Thank you.
Thank you.
Bye-bye.